Ladies and gentlemen, welcome to this latest teaching session in the course on technology and the future of medicine. Today we're talking about the privacy of medical information in the future, and Neelam Sandhu is giving the main presentation. I just have a few remarks beforehand. I wanted to thank you for braving the snow. There have been 10 centimeters, I think, today, and there's still a substantial number of you here, so it's a very good sign. Also, if you find me a bit happier than usual, I suppose it might be hard to tell, but I am very happy because I had put together this proposal for medicine writ large for the Faculty of Medicine's Centennial TED-Med sessions on the 16th and 17th of April. Only 4 people are chosen, and I was one of the 4. Now you might say, well, good for you, Dr. Solez, but you know, what I'm talking about is the course. So it's actually like all of you had applied, and we've all been accepted, and it's just really cool. So so thank you all for taking part in the course, and I think you all contributed to the luck that led to us being selected. This is the page that talks about this TED-Med Live session, where I'm giving a 20-minute presentation on medicine writ large. Those of you who know German will know that although the German words that Virchow used do literally mean medicine writ large, that in German, the meaning of this is a little different. It's like giving something high priority or saying that something's really important. But anyway, that doesn't matter. Most people have always assumed that those German words meant medicine writ large, and so that's what I'm going to assume in this. If you think about this idea and its consequences, one direct consequence for us, the Dean of Arts and the Dean of Science teach in this course, and we had proposed that they would debate each other talking about the same subject, which I think would be really cool. But they doubted that they could come up with a suitable subject, or in the present climate, they could justify this. Now I think with this medicine writ large having been selected as a topic by the Faculty of Medicine, you can argue that when medicine expands, as we're talking about, people employed in the Faculty of Arts and the Faculty of Science have an obvious role in that expansion. And so it does give a kind of obvious topic that they could talk about. And the barrier to that, I think, is the barrier of the privacy regulations. If you think about the lectures that you received from Osmer Zayan, one thing he mentioned over and over was how difficult it's been for him to get the clinical data and the access to patient data that have gone into his studies on AI of breast cancer and other. Welcome. There's still more people who brave the snow. This is good. So for him, this has been a significant barrier. It has led to delays. It's led to projects that on a scientific basis were very sound that he couldn't actually do because of the privacy side of things. So if you think of expanding medicine in a way outlined here, where it's not only disease, but also human enhancement and improvements in society, Faculty of Science and Faculty of Arts have an obvious role in that, but with the regulations the way they are, there'd be no way for them to get access to patient data in most circumstances. And so one can easily predict that things are going to change, and that privacy, as you know it today, is going to disappear during your lifetime. You can imagine in this room there could be little nanobots you can't see creating an image of all parts of the room, and everything that goes on in here could be surveilled, and you couldn't see the particles that were creating the image. So wherever you went, you couldn't tell whether or not you were being surveilled. And how would that work? Well, people wouldn't have enough time. If everybody was being surveilled, human beings could not, survey all that footage. It's impossible. But machines could. So there's no particular limit of the amount of data that computers could handle. So if most of the surveillance was being done by them, first of all, you might be more comfortable with that. Secondly, they could handle it. There's no obvious level at which the amount of data coming in is beyond the capability of machines to handle. So I think privacy and what's going to happen to it and how quickly that's going to happen, and whether that's all something negative, whether we can learn to live with a future world where we're more surveilled. These are very interesting questions. If you just think about you right now today, if you're carrying 1 or 2 or 3 cell network connected devices, the network knows exactly where you are. And if you're carrying more than one, they even have backup for the data, right? They can confirm it. And then there's the record of the calls that you've made and the sites that you're accessing and all that kind of thing. Right now, you need special permission to access that. But you can imagine that the permission that, if you're accused of a crime or if you go missing or something, the police can get authorization to access all that data in real time. You can imagine that a time will come where access is much more widespread than that, and that data is known, so that you can hardly ever go somewhere and have it not recorded somewhere that you were there. So in that sense, I think losing privacy, it's not so much medical privacy, it's just privacy in general, is something one can easily foretell happening. Now, a more regulated world has looked to us from the vantage point of this course like it would be highly desirable in some areas. You may remember the rather simplistic conversation that I had with Michael Woodside. I said, the people doing nanotechnology must be honorable people, and if we don't have regulations around nanotech, it must be that the risk to the world from nanotech is low. And he said, no, Kim, you're too trusting. The world is a scary place, and in fact, there are a lot of people who just don't care about the risks or who would like to proceed without thinking about them. That doesn't mean that they're not there. And so nanotech right now is an area that's completely unregulated. There is no college of, nanotech people, like there's a college of physicians and surgeons. There is no set of rules that everybody knows that governs what you can do with nanoparticles and what you can't. And I think you can see that, well, on the one hand, being more surveilled, having more people know what you're doing, might seem like a bad thing. That on the other hand, having some regulations applied to areas of science that could wipe out huge numbers of human beings it's probably a positive thing. So there is some sort of balance to be found there. So really that's all that I had to say, and I'll now go to Neelam's.
So I should probably let you guys know a little bit about me so you understand where I'm coming from. I'm a very unusual pathologist and unusual physician. I'm in my 3rd year of pathology residency, but my background is actually in IT. I did health information science as an undergrad at the University of Victoria. That's the only undergrad program in Canada. And there are 4 master's programs. One is at UVic, Calgary, Dalhousie, and I think the other one is actually at Waterloo. And I actually did my master's in health informatics as well. And I took a particular interest in privacy, and I actually wrote a paper with a couple of other professors in Australia and New Zealand about informed consent. Ironically, to tell you the fact that I'm a physician, the 2 most important courses that I took were health law and biomedical ethics before I even came to medical school. And I never got any other training around that area that encompassed the very core of what it is when you're a physician. You need to understand ethically what you're doing for a patient, and a huge part of that is protecting their privacy and confidentiality. And the other side of just understanding legislation. Legislation protects me, but legislation can also work against me if I'm not careful. And from this talk today, there's a few different things I wanted you to learn. One of the things is I just want you to be informed about what legislation is out there that impacts you and protects you, but also to see how it comes into play. And what I meant by being a bit of an unusual pathologist is there's a unique opportunity I have here in Alberta, and I still practice clinical medicine. So if you ever come to the emergency department and you need to be admitted to medicine or family medicine, you might see me at the MIS on Saturdays, because I still see patients. And right now I've been working at the medical examiner's office, and that actually takes me outside of Alberta Health Services and puts me in the Department of Justice. And I think I should let you know the frustrations I experience with privacy and information. I have access to Netcare, which is what we collect all of your data on when you come to the hospital. Right now, because I'm working for the Department of Justice, legislation does not allow me to access any patient information. So for 3 months, for anything that I've been doing at the medical examiner's office, because of the legislation, I cannot touch any Netcare data. I have to go by other means in order to access the information. So that just kind of gives you a little bit of overview of kind of where I'm coming from, what I want you to see, and sort of how my background in IT, my current practice in pathology, as well as clinical medicine all kind of comes together. And then my particular interest just in maintaining patient confidentiality and privacy. So I just wanted you to know a bit of background about health information science. This is the core of what my 7 years of education before I came to medical school was about. Looking at how health data are collected, stored, and communicated, how those data are processed into information so that we can make clinical and administrative decisions, financing decisions, etc., and how technology can be used to support these processes. By the way, if you want the PowerPoint, I'm happy to give it to Dr. Solez and he can email it out to you. So the reality of healthcare professionals is we need accurate, and I'm going to stress the word accuracy here. I can't tell you how many cases I've seen where it'll be a female patient and in her history it'll say she had a prostatectomy. That's not possible. Getting that information changed, pain in the butt, to tell you the truth. Just to get it fixed on the next record means having to talk to a clinician, getting it updated, and all the stuff that goes about it. So we also need health information for administrative purposes. As you guys are probably seeing in the news right now, there's a lot of cuts coming to healthcare in all different areas, from meal supplements to people who are traveling, to people's wages cuts, to cutting of actual procedures. So there's going to be longer waits in some cases too. And the one big thing about health information is that patients are mobile. I'm from Victoria, British Columbia, so you can understand that I'm not loving the snow. My parents are having a good time living by the water in Victoria and going for walks, and we're in the snow. So I'm portable, they're portable. So half of my health information, some of it is on Netcare here, and a big proportion of it is back in Victoria, and another proportion is in my family doctor's office. Now, some doctors' offices are automated, other doctors' offices not so automated. This province has been leading the way, and it's one of the reasons that I came here. I've been familiar with what's going on in Alberta since I started university back in '98, and I started health information science in 2000 when I did my undergrad. So there's a lot of things that have been happening in our province. And I recently went to a conference in Las Vegas looking at what they were doing in the States. And there isn't anything in the States that links like 3.5 million people together like we have in Alberta. You know, you can get care in Red Deer, I can access your records in Edmonton. You can get care in Fort McMurray, and I can see those records in Calgary. I can tell you that doesn't happen in BC. The technology platforms are totally different. The island uses something called Cerner. The mainland uses 3 different platforms. There's Eclipsis, there's Meditech, whatever. But the systems are not interoperable. So if you're in Victoria, you get a referral to Vancouver to go get a surgery done, your papers get faxed over because there's no way for the people in Vancouver to access the system in Victoria. We don't have that barrier in Alberta. So that's one of the reasons why Alberta has been leading the way. So this is the mantra of the Health Information Science program: getting the right information about the right patient in the right location to the right healthcare provider while protecting the patient's right to privacy. So this was just hammered into our heads the entire time, so you always knew what your focus was. And right information is a big key factor. There's a lot of variability in what physicians think the right information about a person actually is. There are plenty of people that want to have even more information available than we have. And information is great, but it's appropriate information. More is not always better. And there are some people who err on that side in medicine and some people who do believe that more is better. So getting people to agree on what kind of information we should be gathering and storing is also a bit of a challenge. So privacy is a very important issue, and I've just got a couple of points here about why it's important to people, because it is essential for your dignity, your integrity, and your autonomy. And autonomy of the patient is a very important thing. It's up to you to make the decision. It's up to us to give you the information that you need in order to make the right decision for you, whether that's getting surgery, getting chemotherapy, or whether that's going for blood tests, etc. Privacy is a way that helps you to maintain that autonomy and the individuality, as well as being able to exercise power over your information. That is a huge thing. And I don't know if some of you are aware, but there was a big thing recently on the news about student loans. So I had a student loan from the past, and there was a big breach of security. There was an external hard drive that somehow left its way from the supposedly secure building, and a whole bunch of people's social insurance numbers, as well as their personal information about their address, etc., was available to people out there. So this is a big issue that's being investigated, and people have been told to go online and check to see if your personal information was compromised. And as you all know, credit card fraud, huge area of concern. So imagine your health information if somebody were able to have access to it about things that you don't want people to know. I mean, is it the right of the people that you work with to know if you carry hepatitis? Our belief is no. If you're working in a government office and you have hepatitis, that's nobody else's business but your own. Or if you carry HIV, or if you've had an STD, etc., things that are just more personal. Most people are pretty open about saying they have high blood pressure or they have diabetes. But nevertheless, that information is private. You don't have to disclose it to anybody. So we have to make sure that we maintain the privacy. I'm just going to give you a moment to read this because I just found this to be something a little bit powerful in my studies, and I just thought it might be nice for you to have a chance to see. And it's kind of that last statement at the bottom that really hit me. The right to privacy, it seems, is what makes us civilized. So I have a number of family members that are physicians. If you put us all together, we could run a hospital. And we practice in Canada, we practice in the States, and we practice in India. So I spent a month with my aunt who's an obs-gynae and her husband's a cardiologist. You can't imagine what the record is there. It's about your 8.5 by 11 piece of paper, basically folded, but it's cardboard, and patients carry these around. And every time they come to the doctor, they have to bring this card with them, and we just keep stapling more cards as their file gets more full. An example of my aunt's office, so here's this, pretend this is the desk. There's one patient and her mother-in-law here. There's one patient and her mother-in-law sitting on the door, and behind the curtain, there's one lady on the table. All of these people are hearing everything about each other. So compared to what we do here, we would never do that here. Have like all these different people in a room, but their idea of culture and privacy is very different. And people were just a lot more open about talking about problems from, I'll just give you a quick example. Like one lady was saying the husband was refusing to come and get testing because she couldn't get pregnant. And this lady is just openly saying this in front of all these people in the room and sharing this information, which I can imagine a lot of people here wouldn't do. So it's just good to see that differences around the world. I'm a big traveler. I've been to almost 60 countries, and I continue to travel. But one of the things I do when I go to some of these countries is I pop into hospitals just to see what they're like. So when I was in Bolivia, I popped into the hospital. And a hospital in Bolivia is like a gymnasium. You've got a bed, single beds, and just curtains. And you have like 50 people in one room. They'll be lined up against the wall here, lined up against the wall there. They're back onto the hospital ward versus like just having 2 to 4 people in a room. So you can imagine when they're having conversations, privacy is not really as much of an issue. So I encourage you to do that actually. If you're interested in healthcare or whatever field you're in, it's always good to pop into different places and see what things are like and how things actually work in other countries. It gives you a really good appreciation, particularly for me, working in medicine. Like my family's Indian and I speak Punjabi and I can understand Hindi. So sometimes I take histories. But one of the things you learn when you know another language is about that accuracy of information. Translation from family members is not always so accurate. So it's just something to keep in mind if you decide to go into healthcare. So this is just a point on the fact that the right to privacy is not just something that we want, it's actually something that's recognized internationally. And this is something that's believed by the Declaration of Human Rights, International Covenant on Civil and Political Rights, as well as the European Convention on Human Rights. So it's not just something that people are making up or it's just unique to our country, it's a worldwide perspective. And this is another big part about medicine and what I was saying when I established that relationship. So sure, in pathology, I don't see patients, but whatever comes in the specimen or when I do their autopsy, that's very important. I do not go out there and talk about it. There's a lot of sensitive information that's there, but then also when I see people, so when I see the patients, who's gonna wanna talk to me if they don't trust me or if they don't build some type of rapport with me? And it's pretty amazing when you go back and you track the records, what the patient told their family, what the patient told the paramedic, what they told the triage nurse, the regular nurse, then what they told the med student and what they told you, it's not the same thing in many cases. So people's comfort level is a big reason about why they provide us with information. And once again, of course I respect the person's privacy, but if I need to help them, I need to be able to have their information. And I have had to sit down with people and explain to them that this is the reason why I'm asking you this question and why it's so important, because a lot of people don't want to disclose certain information. Sexual history is an example of one that people are not very inclined to want to talk so much about, but that can be very important depending on what situation that you're in. So it's a sensitive area, and as a physician, it's always something we have to keep in mind, building that rapport with the patient, making them feel that it's confidential, because a lot of teenagers won't talk to us. And they need to make sure that their parents won't access that information. And believe it or not, most of the breaches in privacy, they tend to come from in-house and they tend to come from people that are related to other people. I don't actually have children, but supposing that I had like a 12-year-old kid, I have no right to access their record, even though I have access to Netcare. And it will be audited and it will be seen that I access the record of someone with the same last name. So I came and attended your lecture the other day that you had here, which was very interesting about all the kinds of things that are going on, the prostheses. We have lots of advancements with cardiac technology, point of care testing at the bedside, et cetera, et cetera. But the foundation of medicine will always be the history and the physical exam. I will even go more towards history necessarily than physical exam, because frankly, technology does do a better job. Listening to your heart sounds and whether you have a murmur, I'm pretty sure an echocardiogram will do a better job than me, but nevertheless, I will always check, and the basics are always important. And believe it or not, a big thing about the stethoscope is just touching the patient when they're comfortable with you is one of the ways to build the rapport. So this just last point is talking about, again, without the trust, there's no disclosure of the data. Without the data, there's no information. Without the information, there's no knowledge translation. That was a big theme when I was in health informatics, was talking about knowledge translation. Just because you have tons of data points doesn't mean anything if you can't actually get some meaning from that information. So that's why computers can't replace physicians, because that clinical judgment factor is still a big part. So this is just going to be a very little brief exercise I wanted you guys to do, just because I wanted you to be aware of what's out there. So Canadian federal privacy legislation. So either some of you are sitting close to each other, I see. We'll just take like 4 or 5 minutes, and I just would like you guys to brainstorm, what are you aware of that protects your privacy at the federal level? I'll give you a way that we have our own provincial Privacy Act that protects your information, but at the national level, because people are mobile, what are you aware of? So just take 2 or 3 minutes.
There's the Personal Privacy Information Act.
Okay.
And there's also the Criminal Code, and there's stuff in the Statistics Canada Act. So
okay.
That's the ones I'm aware of.
Anybody else got anything they want to add?
I think there's something about encryption as well. There's a requirement for a certain level of data encryption, which I've come across recently because the university, I think in 2012, implemented a new Privacy Act for data encryption, which I think was based on a state or a federal plan.
There is a particular act that does protect your electronic information, and we'll talk about that. All right, so we'll just go ahead and do a brief overview then. These are the 4 acts that currently protect your information at the national level. We have the Privacy Act, the Access to Information Act. The Canadian Charter actually protects your right to privacy as well. And PIPA is an act that came out in the last decade or so that protects your electronic information. And this was a big deal because all these other acts were only protecting your paper information. So once your electronic information started coming, they had to enact some legislation to make sure that you were protected. So we'll just very briefly go over them. The Privacy Act has been around since 1983, so like 30 years now. And it imposes obligations on federal government departments only to respect the rights of Canadians. And it gives Canadians the right to access and correct their personal information. And it's a big deal to be able to access your information and correct it, because every time you move, that's important. Access to Information Act provides individuals with a right of access to their information. Again, it's only information that's controlled by the federal government. Now, the Canadian Charter of Rights and Freedoms has a couple of sections that support the idea of privacy. So Section 7 talks about life, liberty, and security, and Section 8 talks about unreasonable search or seizure. So the concept of privacy is more or less implied in the notion of liberty. If you have not read the Canadian Charter of Rights and Freedoms, I advise everybody in here to read it, especially when you look at what's going on in the world and to appreciate the rights that you have in this country versus what other people are going through difficulties around the rest of the world. And then the PIPA came back, so it hasn't even been a decade. It's only been fully enacted since 2004. And this is now where your electronic information is protected, because this was a big concern, like I said, for health information, with respect particularly for health information when it came to insurance companies. And Part 1 of this legislation applies to personal information now in all formats, not just electronic, because most of us do have some paper records places and some places that are electronic records. Now, there are a few provincial acts, and we should, just so that you have an overview to understand that provincial legislation and federal legislation kind of have to go hand in hand. So when we do enact provincial legislation, we are enacting it for the best interest of the citizens of our province. So a lot of provinces have the FOIPA, Freedom of Information Protection of Privacy Act. So if you wanted to go and get your records, and I must tell you that I myself did this one time, I can go, and there's usually a 30-day window within which the hospital or your family doctor's office has to provide you with this information. In Alberta in 2001, because of what was going on with Netcare and automation of electronic information, they enacted their own Provincial Health Information Act. This is the act right now that is not allowing me to access my patient data at the medical examiner's office. But Tomorrow I'm working at the MIST, so I'll be accessing patient data. I mean, it sounds like it's a small thing, but you have no idea how frustrating it is. When I could have all this information at my fingertips, when the thoughts are there, I want to access this patient's information to find out why they died, and instead of having to phone their family and figure out all their medical conditions, and I can't do that. So it's one of my little frustrations, and that's one of the future things that we're looking for people to help us on. So today, just to give you an appreciation for Netcare, and I know there are a lot of people in this course are distant, but they can learn a lot about what's going on in Canada and what's going on in Alberta, because Alberta has been a leader and the other provinces have been looking at Alberta. So we are able to do electronic prescribing. So this was really cool for me to not have to sit there and write out like 10 prescriptions and make an error and then have the pharmacist call me back. So now when you go to your family's doctor's office, and I know lots of you guys are young, so you probably haven't seen this, you'll come in, you need a refill on your cream for your eczema on your hands, and it's just simply done. It gets printed, it gets signed, and you take it. And this has really reduced a lot of errors with handwriting prescriptions. Electronic lab results are a big thing. The fact that this information is available online. So I'm visiting my family friend in Calgary, and I go get some blood work done because I'm not feeling good one day, and I follow up with my family doctor in Edmonton. They can access that information. That's a big deal. But just to make you aware of one thing, there's a difference with information between pulling information and pushing information. In British Columbia, electronic lab results are pushed to your doctor. In Alberta, the doctor has to go in and look for the information. So don't always be so hard on your doctor if they didn't know your lab results. They need to know to actually go in there and look for them. PIN is the Pharmacy Information Network. And one of the good things about me being from BC is giving you the perspective that these two provinces work together a lot. Electronic medical records in the family doctor's offices is a project that was started in Alberta that British Columbia piggybacked on and used a lot of the information. PharmaNet is a project that was started in British Columbia that linked all the pharmacies together. This is really big. If you're not paying taxes now, you will pay taxes in the future. You want to know that people are not going around and getting all those hydromorphone prescriptions and buying, you know, like 800 pills that you, the taxpayer, are actually paying for when they don't need it, and then they're going out there and selling it. People have tried to sell me drugs while I've lived here. It's quite funny to me because, you know, I have prescribed drugs, but anyways. So another big thing that's going on is a patient portal access. So right now, I'm sure all of you do online banking. You all have your own portal. I have my own Bank of Montreal portal. The future is that we want you to have your own portal to access your health information. We want to even be able to give you the ability to enter in all of your blood pressures. You got a blood pressure machine at home. I want to know that the latest prescription I gave you is helping. I want you to take your blood pressure 4 times a day. I want to see 5 days of readings. You can upload that information, let me know, and I can look at it. Same thing with your blood sugar levels. So that's part of where we want to go in the future with a patient portal. The electronic medical records in the family doctor's offices I touched upon, and family doctors can access your Netcare data with FOBs, and they have special IDs. So I worked in the Stony Plain Clinic, so if I had a patient that just said, yeah, I had my breast cancer surgery 2 days ago, I can log in from that office into Netcare and see their discharge summary and find out, oh, they lost 250 mils of blood, it was a little bit more blood loss than expected, so please check their hemoglobin. That could be instructions from a surgeon. So we have the ability to do that. And then just a quick point there about other consults, discharge summaries, blood bank data, et cetera. All of that is available online. So it's an amazing amount of information at your fingertips. So the big question, why we're talking about privacy today, is how do we protect it? How do we ensure that the information is kept safe and that the patient's privacy is protected? And again, I just sort of popped in that student loan thing, right? You may not think it's a big deal to lose your social insurance number until somebody uses that number and you're in big trouble and takes out money or whatever. So I also just wanted to highlight, this was a very interesting study, and I think it also provides some perspective when we talk about privacy and the future, what it is the actual Canadian public wants and what do they actually feel. So in 2007, they started doing this survey and they put up the data. And they actually wanted to look at what were the perceptions of personal privacy and privacy of personal information across the country. What are people's awareness of the laws? That's the reason why we had that brief exercise, is I want you to be aware of what protects you. Because if something happens to you and something is breached, You need to know where is my defense mechanism. And this legislation is a big deal. One of the big areas where breaches happen in healthcare are with celebrities. I've got a friend, she works in Saskatchewan, and I helped her get a job there to do with privacy and security, but she was in Ontario before. And they had a couple of hockey players come in. How all of a sudden does the media know the hockey players are in the hospital and what they're being treated for? That was a blatant abuse of their privacy when that information was leaked out. So it's a very big deal, like how everyone's finding Kate Middleton in the hospital in England. Her information has to be protected just like anybody else's. They also wanted to gather some information on perceptions and experiences that were related to people with their use of electronic information. They wanted to talk about secondary uses, and Dr. Solez highlighted at the beginning about research. And getting access to data is relatively challenging. And getting access to the data that's in Netcare is particularly hard, because I work with some people on a committee called the Medical Informatics Committee that involves the College of Physicians and Surgeons. And we have representatives on this committee that want to conduct research to benefit patients, but getting access to this data is really hard. And they also wanted to look at the public's level of trust. So broad perceptions of personal health information in Canada. 9 out of 10 Canadians agree that timely and easy access to personal health information is very important for good quality care. Only about half of the Canadians are concerned about serious mistakes in diagnoses or treatment due to incomplete and inaccurate information. I think the public was being good to us in that way, because inaccurate information has certainly hurt a lot of people. Just another quick case, from the reality. I had this lovely patient, and my way of practicing medicine is I like to go and get the information, and then what I do is I like to confirm it with the patients. I have been a patient before here in Alberta, and I was in the hospital. And I got to say, the 10th person who asked me, do you have any allergies? It's annoying. You've already told the 10 people you don't have any allergies. The least I can do is go look and just say, oh yes, I checked and it says you don't have allergies. I get the perception from people that they feel better, that they know that at least I looked. So I went to this patient and I started saying, well, I'm looking in your history and I have yada, yada, yada. Well, for the last 5 discharge summaries the patient had, it kept saying that he had diabetes. Never once in his life did he have a diagnosis of diabetes. If you have a pre-diagnosis of diabetes, when you come into the hospital, that means getting poked 4 times a day to check your blood sugars. That hurts. Why are you doing that for someone who doesn't have diabetes? Because that inaccurate information keeps getting perpetuated until somebody actually checks and verifies, is this information actually accurate? So I changed that for that patient and made sure that when the person signed out the case and did their discharge summary after this admission, that they would be very clear that this patient does not have diabetes. If an insurance company did have access to that information, that would change for you the moment you say that you have diabetes. So that's a big deal. I mean, the funny thing about a woman having a prostatectomy, whatever, people will be like, that's inaccurate, it doesn't matter. But something like having diabetes on your medical record, that's a big deal. So we'll just go on to the next point. Then they talked about safety and security of personal health information. So 80% of Canadians consider their health information that's out there is actually pretty secure. There's little evidence that the public thinks that any of us are going to use their information improperly. And the truth is, most of us wouldn't. I mean, we go into work in healthcare because we want to help people. We're not there because I really want to know everything about your life. I mean, we try not to be judgmental. That's a foundation type of ethical factor with physicians. So if you know about a person's history, you're there to treat them, and you want to know that information just so that you can provide them with the best treatment possible. So the trust in health professionals is actually quite high, if you're a doctor, nurse, or a pharmacist. But where people's trust level goes down is with the other people that are accessing information, like our computer help desk folks, insurance company, researchers. People's trust level goes down with them. Another area they talked about was protection of personal health information. So there is some mixture in the confidence and how well the information is protected. Like I said, most people think that it is, but there are still some people that don't think that it is as good. And when you hear about breaches, now there are a lot of examples out there of paper information. We are not supposed to really take charts home. There have been cases where people have found patient records in physicians' basements when they're retiring. So the paper information isn't always more safe than the electronic information. There are all kinds of violations that happen with paper documents as well. And paper shredders are really important to have. I don't always find the confidential paper bin as easily in the hospital as I do at the medical examiner's office. So that's important because people do throw stuff in the garbage can. You can find it there and it could have somebody's data results on it. So, and I also thought that this point here, you can see some of the points as we go along, but there was a clear awareness of laws that protect personal information actually was highest in Alberta. In this province, more people were aware of their protection, and actually Quebec had the lowest awareness of the public with what is actually protecting their personal information. And one point they wanted to stress is even if people were aware of their rights, it seemed that few people knew where to turn to if they ever experienced a violation of their personal health information. So for all of you to know, if this ever happens to you or someone, your loved one or family member or friend, the person you go to is the privacy commissioner for your province. Their office is always open, they maintain, of course, security and privacy, and they go and investigate breaches of personal information. So if somebody had asked, like, you know, I'm a provider, but I'm also on Netcare, so I can ask to have my data masked if I want to make sure that my colleagues don't see it. And if it turns out that there's a breach of information, I need to be aware of that, and I need to go and talk to the privacy commissioner about that. So it's a good piece of information for everybody to know. There's always somebody out there that you can talk to if you're worried about your data being compromised. So another question they asked was, what was the public's support for electronic health records? And awareness and support of electronic health records is on the rise. I just told you guys to Google. The patient expects me to know and be able to access information too. So 9 out of 10 Canadians definitely are in support of electronic health records, and that's the way where our future is going. By the way, there's lots of work in this industry, so the reason I'll just throw this point in is the best decision I ever made was to leave microbiology and do health information science before becoming a physician. Had I not gone into medicine, I would have had a fantastic, interesting career. Everybody who goes into this program gets a job. Every single person, it's a mandatory co-op program. People worked all across this country. We had people work in Germany, Australia, in the States. We even have people work with like oil shipping companies because you learn a lot of basics about information and informatics. So project management, systems analysis training, there's a bit of programming. But if you're really interested in technology and healthcare, it's a really good place to pursue potential graduate studies in. Just thought I'd throw a pitch for the school because the person who was my master's supervisor was actually the founder of the school. He's recently retired, but the school has been around for over 20 years. And you got to believe a lot of people definitely ask me, their kids, what should my children do and study at university? And I'm like, well, we need to find you something that'll get you employed. So I always pitch the program. So electronic health records and comfort levels. So having the ability to find out who accessed your health record and when they did that tops the list of ways that help people feel comfortable with their information. So if they knew that someone accessed their data that shouldn't have, and they're aware of it, then they feel a little bit more secure. It's when somebody goes behind your back that people don't feel very good about it. And that goes back again to that student loan situation. They were kind of late in disseminating the fact that the information was compromised, so the public wasn't terribly happy. The other thing that some of the public members would like to see is new legislation that would make unauthorized access of personal health records a serious criminal offense. Right now, it's not. I mean, yes, you could enact it, but nobody really enacts it. It's more like a slap on the wrist if they found out that you were accessing someone else's records. But it has the potential to go farther. And I think the public would like to see that if people are doing this, that there are more consequences for it. And again, it's worth reiterating that most Canadians are not aware of the privacy legislation that currently exists to protect them, but now you guys are aware of it. So, since we're talking about the future, this kind of ties in nicely to what we can do in the future and advances that can be made in this area, and that privacy will always be foundational no matter what we do in medicine. No matter how fancy our robotic arms get, no matter how fancy everything else gets, it always is going to come down to getting the history from the patient and building the trust. Because if you have a fancy robot and the patient doesn't trust you, they're not going to let you do their surgery. Believe it or not, there's a lot of people that have serious conditions, and based on a bad interaction with a healthcare professional, they don't trust that person, they no longer want to seek care from that person. And we don't want to see that happening. So, the public wants to see more privacy assurances, the option of being informed if there's any breach in their information. Access to records. People definitely want to be able to access their records, and they want to be able to hide or mask sensitive information. So to let you know, at the global level right now, your data in Netcare is masked. And if I were to be actually treating you, I need to put in that I am an actual providing physician for this patient, and that's the reason I'm accessing their record. But the thing is, it's global level masking. So for example, let's say you have a urinary tract infection, and that's why I admit you to the hospital. I don't need to know the information that you're seeing your family doctor and you're talking about the fact that you were abused as a kid and you're now getting therapy from a psychologist. Most people would probably want to mask that because I'm here to treat your urinary tract infection. That other information isn't so important. It may be important just that I'm aware, to be sensitive and that you may be seeking some information and help for mental health, but I don't need to know anything beyond that to treat your urinary tract infection. But right now, we can't offer that to you as a patient. I can only mask it at the global level. I can't actually mask it at the specific record type level, what should be available and what should not be available. So that is something that we're trying to work on in the future so that patients can say that I don't want this information released to other providers, but I'm okay with this information being released. So, and then I talked about the patient health portal, something that we're working on. It's going to take some time. So health research is another area where electronic health information definitely can be used, and we would definitely want to use it more, but we need to make it a little bit easier for people to access the information, like the researchers, but at the same time make sure that patient information is protected. And a lot of this stuff, as much as legislation protects you, legislation can also hinder you. So 8 out of 10 Canadians were actually quite in support of electronic health records and information being used for research, as long as their personal information was masked. And in most cases, research studies, we do mask personal information. And definitely getting consent is a really big deal. And that was another area, I'll just highlight on it briefly. I actually did an international study looking at informed consent around the world. And believe it or not, the standard for informing a patient is actually the highest in Canada. The type of information I should be giving to you, risks of complications. I'm just saying the standard is the highest. It doesn't always mean we adhere to it. I could spend like 45 minutes talking to you about getting a blood transfusion, and I'm giving you all the information. But in reality, we don't always have 45 minutes to talk about that kind of stuff. So we do let people know the main information that they need to know. But other places don't even tell patients a lot of stuff. A lot of medicine around the world is still very paternalistic, and it's definitely that way in India. They come there, they tell you a problem, they want you to fix it. The fiduciary side of medicine is not as strong in a lot of developing countries. It's still a paternalistic model. The way we're educated here is it's fiduciary medicine. I'm not here to tell you stuff, I'm here to work with you. So you tell me that you have a problem, we need to sit down and discuss the problem and come up with solutions that help you with your problem. But the decision is always in your hands. And the easiest one to sort of highlight the example with is to do with cancer treatment. There are people, we'll present the information, there are some who will choose the chemotherapy, there are some who won't. And that's the individual autonomy that's left up to you as a patient. You can ask me for my opinion, I can give it to you, but every individual person's circumstances are different. So that's where the fiduciary component of medicine that comes in. And it's something that I've always really strongly believed in. I'm not big on paternalistic medicine, unless you have to be. If your patients have severe dementia, they can't communicate with you, then you have to do the best that you can for them. So this is some of the other area for future challenges, things that we can work on, things that we can brainstorm, potential areas of employment for people who want to work in this area. What constitutes appropriate use of information? Right now at this committee level, we're even setting together parameters, what is appropriate. So Dr. Solez and I are pathologists, right? Typically, what do we get? We get a requisition, it says kidney on it, and that's it. It'll probably say right kidney. It doesn't say that, oh, this patient was having blood in their urine for 2 weeks and the CT scan showed a mass. It just says right kidney. So some of our colleagues think that that means that, oh, because of Netcare, Dr. Solez and I will go online in every single case. So by the way, we get like 90 urine samples in a day. On a day, you could just be signing out urines. I have to go and log into Netcare and check every single one. Did this person have cancer before? Am I checking for cancer? Is it because of blood, etc.? So that's a big area that is becoming very challenging for us. Yes, information's available, but how it's being communicated. You're asking me for a consult and all you're telling me is right kidney. You didn't even tell me if it was a mass or if it was, on the CT scan. So that's one of our big areas of what is appropriate use of information, what is appropriate communication. Just because it's on the computer, that isn't, in my opinion, that doesn't mean that you just get to hand me an empty requisition. I need to know why you were doing that test. And in actuality, that is protected for me in provincial legislation. A patient's name, their identifying information, brief essential details of their history are supposed to be provided on a lab requisition. That's actually my research project as a resident, is to go and educate my resident colleagues that you need to give me this information. Because if I were right now, when I'm doing medicine, and I need a cardiology consult, I don't just get to write cardiology consult. No one will come and see my patient. I need to say, this is a 65-year-old man, and it's known that he has high blood pressure and cholesterol. His ECG findings are this. I'm concerned that he may have had a heart attack. Can you please come see him? Because that's how you communicate with your colleagues. Paper records, another issue. A lot of information is on paper records, and even though it's electronic, we print a lot of stuff. So when I go to Emerge records in this province are all done by hand. They're actually scanned onto a PDF file, then they're uploaded into Netcare. So you have to wait till they're scanned. So Emerge is an area that's hard because the patient might come in Monday, we might send them home because we think they'll get better. They come in at 10 o'clock on Tuesday morning because they didn't get better, and that record is not there. So then we have to go and find the paper record, pull that chart, look at what was done, and go from there. And maybe it's time to admit the patient because they're not getting better. So medical knowledge quadruples every 4 years. It's an insane amount of information. And there are so many studies and research papers, and the reality is, and I'm just going to say it, you can manipulate the data to show whatever you want. You can choose to look at certain studies, and you can show this. One of the banes of my existence as a med student was a cardiologist who kept changing the beta blocker. It's a medication that lowers people's heart rate. Every week, a different cardiologist had a different preference. I like metoprolol. I like propranolol. And each week, we would be like changing the patient because of the information that they were shown, whether it's their own research or a pharmaceutical company. It's a challenge. One of the other areas of health information science that was great is there's a professor named Dr. Malcolm McClure, and he was part of Harvard and part of the University of Victoria. And one of the things that he led some research that's saving the public money and providing good care was on statins. Those are the drugs like Lipitor that lower your cholesterol. Well, he put a bunch of people on Lipitor and a bunch of people on a generic name and did a large-scale study to prove that the generic drug was just as good as the name brand drug. So our provinces fund things differently. And in British Columbia, our policy for funding is to fund the generic drug. Otherwise, the patient has to pay for it. Unless I can show an excuse that you need the name brand drug. So I have to show that you used the generic drug, you failed on the generic drug, then I can make the argument to have the name brand drug given to you, which is not actually a bad policy. It just means trying it. But once again, pharmaceutical companies, name brands, they want you to sell their drug for a lot more money. So that's a big area of medicine. There's different inputs, but just to give you another example. Insider attacks, like I talked about, looking at your kids' information, looking at your siblings' information, you don't do that. Data encryption is another area that has got a lot of advances that are going forward in the future. Being able to protect that data, the firewalls. Every year we're hearing about some worm virus that some 15-year-old kid, in their basement came up with and just plastered all of our information. I mean, who hasn't been hit by a virus attack? And our university here gives us free access to, if you didn't know that, gives you free access to firewalls. You just type in your CCID and you get access, which was a big deal for me because I did not have my own on my computer. It expired after a year, so I'm using the university one. Another big challenge is interoperability between systems. So like that example I gave you in BC, Cerner in Victoria, Meditech in Vancouver, Eclipsis at St. Paul's in Vancouver, they don't all communicate with each other. So getting information to communicate is a big deal. One of the big strengths about the electronic medical records in the family doctor's offices is what the province actually did is they set out a list of standards to make sure that they were interoperable, so that you could choose from 6 different vendors. If you chose one of these 6 vendors across the province, these electronic medical records are interoperable. So one could be using MedAccess, and one could be using, I think another one was called EPIS. And both of those systems could talk to each other. So the province actually forced the vendors to make interoperable standards, or they didn't do business with them. So that's a lot of power that comes from the government side. Cost factor is huge. A lot of things are happening way slower than we anticipated, especially at this committee that I sit at. We wanted to have a patient portal functioning now. It's coming in the future, but cost is a big part. Support is a big part. The IT people, the personnel, the educated training people, getting them in, getting enough of them to be able to do this, very challenging. Governance models, another big challenge. And then there's my medical examiner example, right? Access to the system. I'm just trying to fight to get access to the information. Forget what more information and how much better it can be, but just getting access. And I didn't even have access to radiology information when I first started residency. And I had to put my foot down and I demanded, you must give me access, I'm on call, or it's gonna be a problem for patients. So, and then again, my question is, more data actually better? I don't actually have a smartphone. I hate texting. I'm not a big cell phone fan. I still have my prescription list on my Palm Pilot, but I've been told by Hippocrates that they're not supporting Palm Pilot after a year, so I'm probably gonna have to give in and get an iPhone. It mostly comes from the fact, obviously I like to talk, so I don't like to text. But I have the texting feature for people to do. So it's, again, more data. Like, there's zillions of applications that can assist you in medicine, but just accessing them and going on them, it takes a lot of time to figure out what it is you need. You know, the fastest thing I want access to are lab results, imaging results, and my prescription data bank. And through Netcare and my Palm Pilot, I have access to that. So that's good for me. And again, data accuracy is a really big issue. It's a really big issue. So I'm going to stress that one particularly, because inaccurate information perpetuates more inaccurate information, and the trend just continues. So I'm just going to conclude with our health information science mantra, that the right information about the right patient and the right location to the right healthcare provider while protecting the patient's right to privacy is the foundation for basically anybody who's working in healthcare. And you will be surprised at times when you don't have the right patient. There was a case in Victoria where we had 2 patients in the room with the exact same last name. So yes, the nurses checked their ID bands, but one lady's name was like Martha and one lady's name was Nancy. And the blood needed to go to Nancy, but by accident it went to Martha because their last names were the same. And it was ABO incompatible blood, and that resulted in a patient death. It happens rarely, but it's the biggest example we quote, because with that information you don't verify with the patient and you don't check everything. These are the kinds of things that can happen. So as much as privacy is a big part, the information that you're actually trying to protect is an even bigger part. So that's it for my talk today. I think I was kind of within the 45 minutes I was supposed to talk for, so happy to take any questions, comments.
Hi, thanks very much for your talk. It was very interesting. I just have a very specific question about data encryption, because recently I've had some trouble with that myself because I'm in research. There's a lot of patient data flying around. I was just wondering if you had any personal experience with data encryption and any problems that arose, because at the moment I can't find a software that works. It just kept crashing my external hard drive, and I know it's a really big issue, but at the moment we don't have any data encryption because we can't find anything that works.
Personally, not really. The extent of kind of my techie part was a bit of programming. I learned to program with Visual Basic and Java. But the actual encryption, myself, I don't know, but I would really recommend talking to people in our IT department.
Yeah, I did that.
No? No help? Give me your name. I have some friends in this area, some particularly good people. And if you just give me your email information and what your request is, I'll forward it out. Because there's quite a few techie people I have in the industry from my undergrad and grad knowledge. Maybe we can help you with that.
Great, thanks very much.
Okay.
So kind of on the topic of data encryption, but a little more theoretical, do you think in the future with the rise of technology, there will be a point where data encryption either cannot be strong enough to resist, code breaking, or if you won't even need to break a code to get the data you want. And for instance, sci-fi or nanobot machine, I need to find out what that person over there has got wrong with him. I'm just going to go get my nanobot over there, and I don't even need to break a system to find out that information. I can just find it out myself. Do you think that's something that could happen, or if there's going to always be a defense for the offense?
I don't really personally believe that that would happen in the future with your private information. That's the whole purpose of having the legislation that protects you, and the legislation is always being changed. Like my inability to access information right now, I've already spoken with the people, and they're in the process of amending the legislation so that I can access the data when I'm at the medical examiner's office. I wouldn't want to be in a place where it was, I love that information's at our fingertips on Google, and I'm amazed at what people post. Like I wanted to look at, some histology, what's the right phrasing I should use to explain stuff, and like patients were actually posting what their pathologist wrote on their reports, after she had a spontaneous abortion, like what the information actually was. The biggest risk, I think, that's happening with us right now in our industry is the social media use. There has been couple of major breaches of patient information. I myself was witness to some posted on Facebook. So that is the biggest concern about why I don't think that this will become a problem in the future, because there are measures in place, and as soon as these things are identified, we do take steps to make sure that it's protected. And that is why it's so pivotal that we do have an unbiased, nonpartisan privacy commissioner in every province, because those people are really the people that protect us. All of us can make arguments about why we should have data, but those people's job is to make sure that only the right people access the data.
Thanks.
Can you tell us a little bit more about how you feel we're going to make data more accurate?
Well, for all of us, it's part of it is up to us as well. Like when you move, for example, your banking records, like, okay, I'll give you a personal, real quick example. Banking records, right? Apparently, I had opened a student loan when I was a med student in Vancouver, and one of the credit authority questions they ask you is what branch was it opened at? I didn't remember. They don't give you the city, they just give you like a street address. And I lived there like 7 years ago. So I actually went ahead and called the credit bureau and found out the information so that I could provide the correct information the next time. So part of the onus is on the individual. But for me, for healthcare, I can't afford to be wrong. Like if you are, especially in an area like pathology or when it comes to blood products, like if you are in fact B positive and I didn't take the time to make sure they were B positive and I try and give you A positive blood, I can hurt you. So the onus is definitely on us. And that is why healthcare is challenging, because you want to trust your colleagues. And generally medical students do really thorough histories and physicals. But then again, you need to make sure that that information is correct, which is why 10 people ask you about, do you have any allergies? But there are more efficient ways of doing things, and probably talking to the patient at one time would probably be helpful, that everyone can get the information that they can. But I always want to say that some of the onus is definitely on the patient, and that's why I don't like that paternalistic model very much. Like when people come to me and I'm like, well, what medical conditions do you have? Like I just went to a scene the other day, and the man had 15 medications on his table. And you ask his wife, what medical conditions does he have? And she doesn't know. And he doesn't even know. And you just have to take the time to sit with the patient and instruct them, like, any basic surgeries you've had, any medications and the dosages, I want you to write it down and keep it in your wallet. And that has really helped us in a lot of ways. But because people weren't doing that, that's why we came up with PIN. So now if you're unconscious and you come in, I log into the computer system, I can see all the meds that you've been on for the last 6 months, the last 12 months, or the year. And it's all uploaded, and now even the cancer information is uploaded. So if not only are you getting medications from your Save On Foods pharmacy, and you're also getting medications from the Cross Cancer Institute, that information is all available. So all the time, the people who are the health data stewards of our systems, when we find deficiencies, we're always trying to improve what information is available. So that was a big problem, because patients, I don't know the name of all the chemo drugs. I don't blame the patient for not knowing. They have long, complicated names. But it's a big deal if you come in and I'm trying to teach you because you have a fever. When you're on chemo and you have a fever, that's a big, scary thing. You need to make sure you know what medications that person's on. So encourage your friends and family members to be aware, because these questions come up all the time, and they really can mean life or death for your family member.
Alrighty. Do you think as accessibility of information and the accuracy of all of it becomes better, do you think the rapport that physicians need to build with their patients will start to decrease? Because if it's more accurate than just in the progress of saving time, would they not try as hard to, build a better connection with the patients?
Well, I mean, the patients definitely have a lot of expectations of us too. Some patients think it's great if I whip out my palm or you whip out your smartphone and you look up something. And some patients are actually like, but you're the doctor, shouldn't you know? And that's when you bring out your CPS book, which shows all the drugs, that's this thick, and you're like, well, it's kind of hard to memorize this entire book, but I will go and check. I think so. I mean, patients, the biggest thing that I learned, which is why I meant those 2 courses I took were really good, patients don't sue people that they like, even if you make a mistake. And your job as a physician is always to have a good communication interaction with a patient. It's a tough job, without a doubt, and you have good days and you have bad days and you have people yell at you. But at the same time, all these experiences you have in your life, they add to that. Like, I've been a patient, I've been there for a family member, I've had a sibling that's had cancer. And you just have to try and put yourself in those people's shoes and say to yourself, like, they're going through a rough time. They don't mean to yell at me, but they're going through a rough time. I guess the reason I'm giving you that as an example is you're right about accuracy, but data doesn't remove emotions. And medicine and healthcare is filled with emotions. And so a lot of the information people provide, depending on their emotional state, is very different. When they're very upset, they can't provide as accurate data. So sometimes for these people, you step away and you come back and you talk to them when they're in a better place. So, I mean, I would like to see that. I would like to think that everything I see on Netcare is accurate, but I think I've given you some examples where I see things are not accurate. And if I don't check, then that means my patient won't necessarily be getting the best care.
So I guess you've somewhat addressed this, but do you agree with the current privacy legislation, as well as do you think in the future maybe privacy will be slightly more lax so that it's more convenient for medical professionals, or do you think it's going to be a lot more stringent?
I think as time goes on in the future, at first it was more lax, which is why people's information was ending up in certain cases in the wrong hands. It's one of the reasons why I stress to you health information science as a program. One of the things you can't outsource is healthcare. We don't ever want to outsource our data because there are other people's legislation that impacts us. There were huge concerns when the Patriot Act came out in the States. Because in the States, basically, they're saying if it's for national defense, we can go and access whatever information we want. Those of us who work in the privacy realm in Canada never want to see that happen in our country. It's one of the reasons we don't give business to a lot of American companies, because those companies are bound by that act that allows them, if they're housing the data, so if we start taking Vancouver data and house it in Seattle, if the government in the States wanted to access that data, they have the right to according to their legislation. So some of the companies that wanted to do this that were American for some of our electronic medical projects and some of our other additional projects were not given contracts if they were from the States. To be honest, when it comes to your personal health information, because I'm exposed to so much, you don't ever want it to be laxed, or your personal information with respect to fraud. Like my poor neighbor was in London and her passport just got stolen. So the Canadian consulate did call our house and verify, is this lady real? Does she live next to you? Like, these are the reason we have these measures in place to make sure that people are protected. Credit card fraud is a huge problem. And yeah, it would be wonderful in the future to carry all your information on a credit card. I think that would be great in a lot of ways. But of course, I would be concerned. What if your wallet fell out of your pocket? What if somebody pickpocketed you and your whole record was all of a sudden lost? But one of the things that I want to see in the future is I want to see people accessing their data more. As a physician, I want you to care about your health. That's why I'm into fiduciary medicine. I want us to work together so that you will get the best health care. But because of the sensitive nature of the information I see, it's a big deal. Like these insurance companies, I recently tried to apply for health insurance, and this was like 6 months ago, and I was a lot heavier. I've lost a lot of weight. They didn't even want to insure me with not a single medical problem and just being, I was obese at the time. If they found out, like I said, with that man who had the diabetes, they wouldn't insure him. They will find a way to nullify your policy any way that they can. And this is a huge issue with HMOs in the States. And these talks come up on Dr. Oz, they come up on 2020. My family's a big 2020 60 Minutes watcher. And these are huge problems with people's information that's not protected, and then what these insurance companies try and do, and things like the Patriot Act that allow people to access information. I would hope in the future, I can always go to the patient, like even as a pathologist, if I keep calling that surgeon and I need information and I can't get it, your phone number's in the computer system. I can always reach the patient. You can always go to the source of information. I agree it's extra work, and there are many days when we wish that more information was a little bit easily accessible, but I would never want my access to compromise somebody's privacy. So I would not really be as in favor, and in the future, I don't think that privacy will be necessarily more stringent versus more relaxed. I think it's just more of an appreciation of what needs to be protected and how is the best way to protect it while making sure that people can access it. Because access is just truly the most important thing for you to be able to access your own information. Yep.
So David Brin, who is both a very successful science fiction writer, but also writes nonfiction, has written a book, The Transparent Society, and it's probable that for most physicians, most people working in health, the predictions in that book are so shocking that they just don't want to think about them. But I don't think that means that it's wrong. And I think that the future you are thinking of, that's very similar to the present today, it's absolutely impossible that in 30 years that will be the case. In 30 years, in essence, privacy will be gone. I don't know how, but in some way it will be. And there will be a lot of things that are much better than they are now. But that aspect, your own personal privacy of if you go somewhere that no one else except you knows that you're there, that will almost never be the case.
Oh, now, yes, yeah. I agree with you.
And by extension, I mean, when you think about, one of the strange things about, developing countries is that in many of them you can walk into a pharmacy and get any antibiotic that you want. Yep. And it may not be what it says on the label. It may be something that will kill you. It may be something that has no active ingredient, but in that country, it's the best product you can get, and you can get whatever you ask for. And so, in a sense, they have a kind of freedom that we don't want patients to have. We don't want them to be able to get any medicine that they want because they'll make a lot of bad choices. So I think that also, the possibility of individuals deciding on their own treatment, even though they know nothing about it, this will also become much more common than we might think. So the kind of linear expectation that, 10 years from now things will be just about like they are today, only a little bit modified, that is not going to happen. I know it's an easier way to think about things, but I think, Matt's question of will there be many other ways to access the information about somebody's health? Will it all be controlled by a central authority? I don't think that it will be in the future.
I don't think so either.
It's impossible. Yeah.
I do agree with you that that notion is definitely there. Like access is getting easier because of technology that's out there. But if there aren't means to want to protect that information, and if that becomes sidelined until you suffer the consequences of your information being out there, I'm not going to hire you because you're HIV positive. I'm not going to hire you because you have hepatitis. Oh, you've slept with 30 different people? I'm not going to employ you. So it depends on what you look at information and how sensitive and how much it affects what area. Like I said, you know, most people openly admit they have high blood pressure. Most people don't openly admit that they have or have had an STI or sexually transmitted disease. So I do agree, and that's one of the reasons why a lot of these committees are set up. They take a lot of input from the public, and they conduct some of these surveys to find out what it is people actually want. I mean, when I saw my aunt and all those ladies in the room, there's no way I would have been comfortable talking in front of that many people about my relationship with my partner and having children. But in that society, it's acceptable. And for some people, when they move to this society, a lot of people think that it's too much in their face and people get put off by it. So I do agree things will change. I just want to see that information still be protected. And there are people that are out there that are trying to make sure that it is.
We're out of time. Thank you very, very much for a really outstanding talk.
Okay. Thanks, everybody.